So to continue from where Alfred has left off, he's made my work a lot easier. Yes, we will be looking at the realities of anti-epileptic drug management. What are the ideal treatment strategies? So basically, we're going to look at the diagnosis and understanding of epilepsy in Africa, the practical challenges in Africa, as well as practical treatment strategies. And then at the end of this, then we shall open the floor to discussion. So basically, we have looked at epidemiology today. We understand that epilepsy is a big problem. It accounts for 1% and sometimes been quoted as 2% of global disease burden. 65 up to 70 million people are affected. And then we also have 500 million people indirectly affected because these people live with families, live with children, live with relatives, and all these people are affected by epilepsy in one way or the other. So 80% of the people with epilepsy live in low and medium income countries. So therefore, this burden is significant in these countries, and they do not have the resources to actually deal with this condition in an optimal manner. In this region, the treatment gap averages 56% in one study, but we know that this is very heterogeneous. In some areas, it goes up to 80%, and in Kenya specifically, we have a figure of 74% from the Kilifi studies. So what are the local understandings? What goes on in Africa? What do people think about epilepsy? So regarding etiology, there's lots of published data, but two studies say that a lot of the people in Nigeria and some in Tanzania really consider epilepsy to be a curse, something you cannot do much about. Some think it's your destiny, you were born to get epilepsy, and quite a few think that you get it through heredity, and in a sense they are correct because we do know that genetics does play a huge part in as far as etiology is concerned. The other thing that causes concern is that some people believe that epilepsy is punishment for doing wrong, either by self or by a near relative. How sad could that be? Then, unfortunately, also, in parts of Nigeria, people think that epilepsy is a contagious condition which you can get by touching somebody's saliva or just by sharing their utensils, the same way you would for tuberculosis. There are effects of these sort of understandings, especially so where people think that epilepsy is a condition that makes one unable to think. To some extent, there is some truth in that, but you know that when people are well treated, then of course their cognitive ability improves. There are people in Tanzania who also believe that once you have epilepsy, you are completely unable to work, should not be allowed to work, and should not attend school. They also believe that people who have epilepsy should not have children. And therefore, this has huge social implications. It is also thought locally that that epilepsy is a condition that actually makes one completely unable to fit in society and therefore deserves isolation. Therefore, discrimination, isolation, and lack of hope have been published as some of the things that have been clearly identified as effects of having epilepsy in the African society. Therefore, a diagnosis of epilepsy induces fear. It causes significant repercussions for family and immediate relatives. Nobody wants to be related to somebody else who has epilepsy because it means that they too are probably also having a problem. These things, these ideologies or these ideas, therefore, lead to significant difficulties with acceptance of the diagnosis of epilepsy. It makes it more difficult for people to look for acceptable care, and even when the diagnosis is made, they may not accept it. And when people think like this, then even conventional diagnostic procedures, these will be treated with significant skepticism. There are people who believe that epilepsy cannot be diagnosed or treated in a conventional manner, and therefore the first choice of care would be a faith healer because that's the person who understands spiritual matters. And in a significant number of studies, people obviously chose to go for herbal preparations because they thought that that was what was appropriate. In some cases, as has been pointed out by Alfred, they would have liked to use other medications, but there were issues of cost and availability. In a few patients or in a few societies, they believe that this is a condition that can only be managed using duotherapy. To some extent, we shall discuss this further, to some extent they could be true, they could be correct. Then, unfortunately, there are also beliefs that epilepsy is incurable. So these sort of things then cause practical challenges because of the belief systems. And then it is a fact that in Africa, we will have a higher prevalence of epilepsy cases compared to Europe or the developed world, simply because birth asphyxia continues to be a significant problem. We have discussed CNS infections, notwithstanding the burden increased by the presence of malaria, meningitis, and HIV. We also have low vaccination rates, also the lack of pneumococcal, meningococcal, as well as Haemophilus influenza B vaccines in large parts of Africa. And of course, we've talked about infectious diseases. We have this morning looked at how great the paucity of skilled personnel is, and sometimes the community health worker, who really isn't a skilled healthcare person, may be the first point of contact for somebody with epilepsy. Therefore, the diagnosis may or may not be made. In many parts of Africa, we also have poor or non-existing referral systems, and sometimes where they exist, they are not appropriately supported. We've talked about the economic inaccessibility of services, and therefore, this impacts on the availability of anti-epileptic drugs. We have very limited capacity for drug level monitor. It may not be required for every case, but where you have intractable epilepsy, clearly this would be an added advantage. We have almost non-existent epilepsy surgery centers. It's rarely offered. None of our patients in our hospital is on ketogenic diet, and none of us has the hope of none of them is also able to access vagal nerve stimulators. So we have few functional health facilities. Our referral priorities do not include epilepsy because this is something that causes disability. It may not kill the person immediately. We have talked about few functional EEG and imaging facilities. In fact, the WHO actually realizes or reports that only 39% of low-income countries have regular availability of EEG and imaging facilities. Then, of course, we also have other reasons why patients will have adherence issues. If you if you walk 5 kilometers to a health center and you find that the medication is stopped out, we do not have the most basic anti-epileptic drug, then therefore your adherence is affected, despite the fact that you are willing and wanting and needing the anti-epileptic drug. In Africa, we have huge issues. We have guardian-related difficulties. The number of orphans are increasing. These are children who need somebody who is understanding of what they need and also gives it to them consistently. And when you're an orphan, sometimes that person does not exist. So what do? We do have practical solutions. We've gone through some of this morning, and basically creating general population awareness and an understanding of epilepsy, that would help. It would help people come through and probably seek a diagnosis. It is also known that individual patient counseling, this was a study from London, does help with understanding what epilepsy is, adhering to medication, as well as, to some extent, improving outcomes. We should also try and ensure that medical personnel on the ground also have a good understanding of epilepsy syndromes. I've had parents who tell me, how can my child be having epilepsy? I have never seen them shake, salivate, or urinate on themselves. Yet what you're actually talking about is childhood absence epilepsy. We therefore also need to involve our government agencies, because these are not things that, as an individual practitioner, you're able to solve on your own. So advocacy continues, and our ministries of health must be informed and involved. Now, we have talked about anticonvulsants. We have said that phenobarbital is helpful, it's useful, it's effective, and it's cheap. But we also need to advocate for the availability of other medications that would benefit majority of our populations. Medications such as prednisone, which we now know is cheap and is helpful for infantile spasms, should be consistently available in addition to all the other medications on that list. The other thought is that within the public sector, we should advocate for certain medications to be available on a named patient basis. Not everybody needs levetiracetam, not everybody needs vigabatrin, and certainly not everybody needs tirpental. But for the most needy of our patients, we should try and we should advocate that these medications are availed. These medications need to be consistently available. We've talked about drug banks, which sometimes help plug the gap. There are thoughts that if we manufactured some of these medications locally, then the issues of cost would also go down. And definitely, we need to integrate epilepsy care into primary health care. We need to judiciously use what is available and use it such that it minimizes side effects. We need to have convenient schedules, right, where a mother has 6 or 7 little kids, once daily dosing, drugs that can be given once a day or at least twice a day would probably go a long way in ensuring adherence. Then, of course, we need to try and use safe dosage ranges. And where it is possible to determine an etiology, then we really need to go for it. Where surgery is available, especially so in some of our bigger centers for resectable lesions, then this should be offered to our patients. Surgery for hydrocephalus, treatment for infections would also help reduce the prevalence and the new cases of epilepsy. Child advocacy, we cannot leave this room without talking about that. We need to advocate for the availability of appropriate evaluation and care, appropriate education, as well as social grants for families who struggle with children with epilepsy. Appropriate school placement is important. The psychiatric services legislation to discourage discrimination. And also we need to work on work placement and encourage economic self-reliance because, as you know, anybody who has epilepsy, one has a right to live a normal life and therefore also has the right to self-determination, which can be encouraged by being economically self-dependent or self-reliant. Alfred has already touched on this. We need to work with our traditional healers. We need to cooperate with them. We need to educate them. And what he's pointed out, the fact that in his country they were very willing to work with them, we should not ignore that. We should recognize their role. We should educate them about our own role and encourage referral. So in summary, epilepsy is a significant health problem. We have belief systems in Africa that impact on diagnosis and treatment. We agree we have a paucity of services, but there are strategies that we can invoke in order to provide the ideal treatments. So with that, thank you very much, and we shall open the floor to comments.